Hello, my name is Patricia McQueen. This presentation describes the program development of a virtual clinic to improve clinical symptoms of patients with intermittent claudication. This presentation is part of the biostatistics course taught by Dr. Vicki Krenz in the first California State University and Fresno State University joint Doctorate of Nursing Practice program. Peripheral arterial disease is a progressive disease and occurs when plaque accumulates in the arteries. Vessels in the legs are those most often affected. Peripheral arterial disease is unusual in persons younger than 50 years of age and becomes more common as people get older. Risk factors of peripheral arterial disease are the same as those for atherosclerosis, namely smoking, hypertension, diabetes, obesity, and dyslipidemia. Peripheral arterial disease is a debilitating atherosclerotic disease of the legs and is associated with an increased risk of cardiovascular morbidity and mortality. Intermittent claudication is caused by restricted blood flow and, consequently, impaired oxygen delivery to the muscles of the legs. Anaerobic byproducts then accumulate and cause leg muscle pains, cramping, and fatigue brought on by physical activity but relieved by rest. If left untreated, peripheral arterial disease may progress to critical limb ischemia, which is also known as muscle pain at rest, ulcers, skin and bone infections, and ultimately may require limb amputation. A patient with intermittent claudication has reduced physical and social functions and a lower quality of life. Treatment of patients with intermittent claudication includes improving their abilities to walk further distances and thus improve their quality of life. The American College of Cardiology and the American Heart Association guidelines for the management of patients with peripheral arterial disease recommend a program of supervised exercise initially, performed for a minimum of 30 to 45 minutes 3 times a week for at least 12 weeks. These guidelines consider that the efficacy of unsupervised exercise programs is not well established, but Garner, Parker, and Montgomery conclude that home-based exercise programs are just as effective as supervised ones. These aforementioned studies support the efficacy of both forms of exercise therapy for patients with intermittent claudication, but fail to specify details for performing unsupervised exercises, the therapy most often prescribed. Medical providers who recommend an exercise program should consider supervised and unsupervised therapy. Supervised exercise therapy is limited by availability, cost, insurance, and transportation issues, while unsupervised home-based therapy is low cost. The desired outcome of treatment is to improve a patient's walking distance and mobility. The virtual claudication clinic model is designed to monitor home-based exercise regimens attendant to the treatment of intermittent claudication and peripheral arterial disease. This model is important in the modern U.S. healthcare system because of the rising healthcare costs, because of limited transportation issues for patients, and because of the high cost to patients. This model would also help save time for the patient and reduce workload in the clinic. This would free up time for the surgeons to perform surgical consults for those patients in more dire need. The program is valuable in that patients with intermittent claudication can deteriorate quickly, and if left untreated, the peripheral arterial disease may progress. Denial also plays a large role in patients who ignore their symptoms, and follow-up clinic visits are generally in the form of discussion and rely on symptoms. With this program, a nurse practitioner-led clinic can monitor closely a patient's exercise tolerance and progress. The purpose of the study was designed to assess the outcomes of a structured home-based exercise program for intermittent claudication and to examine the number of patients who did not complete the program. The design and methodology is a retrospective cohort study performed in an academic community medical center. 120 patients with peripheral arterial disease and suffering from intermittent claudication symptoms were enrolled. In the design of this study, the inclusion criteria included the diagnosis of peripheral arterial disease with ankle brachial indices, or ABIs, of less than or equal to 0.9 in at least one leg, and they all had intermittent claudication symptoms during exercise. The exclusion criteria in this study included those patients with gangrene, ischemic ulcers, Berger disease, rest pain, walking distance less than half a block before ischemic pain onset, chest pain, dyspnea, or arthritis with exercise. The design of this study included a pre-program initial claudication distance and absolute claudication distance were obtained using treadmill tests in the clinic. The patients were provided a perceived pain scale of 0 to 4, with 0 being no pain and 4 being severe or maximal pain. The test ended when maximal claudication pain was reached, and the distance in meters to the onset of pain and to the maximal claudication pain was recorded. Patients completed the initial evaluation and were seen by an exercise physiologist for instructions and education regarding exercise. They were instructed to complete at least 30 minutes of walking time 3 to 5 times per week. They walked until their ischemic leg pain was near maximal, then rest until pain was resolved, and then they were instructed to continue walking until they required their walking time. The patients were given journals which readdressed goals and lifestyle modifications required for success. It also reviewed the plan for regular exercise needed for improvement as outlined by the exercise physiologist. During the program, patients received regular feedback and follow-up with the exercise physiologist. The patients returned at 6 months to be reassessed using the treadmill test at the clinic. The statistical analyses used were a 2-sample students' t-test and chi-square test for comparison of the completer and non-completer data. Paired t-tests were used to determine whether changes occurred pre to post in claudication distances. A p of less than 0.05 was considered statistically significant for all tests. The results showed that of the 120 patients meeting inclusion criteria consenting to the program, 41 returned after 6 months for the second graded exercise test. This was a dismal completion rate of 34.2%. The mean intermittent claudication distance of the group who completed increased from 103 meters to 192 meters, an 86.4% improvement, with a p of 0.001. The mean absolute claudication distance increased from 400.9 meters to 480.1 meters, which was a 19.8% improvement at a p 0.006. The most common non-medical reason found in 47% of those who did not complete the program was not keeping the follow-up appointment. In conclusion, the home-based therapy is effective in improving intermittent claudication in patients with peripheral arterial disease who successfully complete the program. The second portion of the study examined the large number of patients who did not complete the program. The researchers were hoping to identify patient characteristics that would help predict which patients would be likely to complete home-based programs, but no trends were found. Supervised exercise programs have inherent structured support and engagement and give higher workloads of exercise. The nurse practitioner's goal is to provide better patient care, which leads ultimately to an improvement in the patient's symptoms associated with peripheral arterial disease and claudication. By increasing the patient's walking distance and ability, and with the current trend in healthcare to maximize efficiency and reduce cost, the virtual claudication clinic program is a sure success in the vascular surgery center. As patients learn the benefits of healthy behaviors, decreases in claudication symptoms improve patient outcomes, and, undoubtedly, the desired outcome is a durable quality of life.